for having both of us at your event today. It sounds like you've had a really interesting morning. My name is Jo Reeves. I'm the Prevention and Health Inequalities Network Manager for Buckinghamshire, Oxfordshire, Berkshire West Integrated Care Board, and I'll let Rashmi introduce herself.
Hi, I'm Rashmi Soni. I'm a GP in High Wycombe in Buckinghamshire, and I'm the BROP Prevention and Health Inequalities Lead.
So I'm not an expert, a subject matter expert on cancer by any means, but what I do want to do today is try and prompt your thoughts about the ways health inequalities are present in people's access, experience and outcomes around their cancer care. So I hope that you are familiar with the Core 20+5 approach, and this is a national NHS way of reducing healthcare inequalities. It's a lens rather than a prescriptive programme, and it's broken down into 3 parts. So the first is looking at the Core 20, which is the 20% most deprived population across England. Involved, that equates to 57,000 people. And that's important because people from our more deprived populations develop poor health 10 to 15 years earlier than their more affluent counterparts, and they are more likely to die earlier. So across BOB, we have a life expectancy gap of 12 years between our more and less deprived areas. The plus is our ethnic minorities, our people with learning disabilities, and people from various socially excluded groups. So that might be people who experience homelessness, sex workers, vulnerable migrants, etc. And we know that their early mortality is far worse even than looking at deprivation. They're often invisible in data sets as well. We can face multiple barriers to their healthcare, etc. So that's another helpful lens through which to look at health inequalities. And then we have the 5 clinical areas of focus identified because there are stark differences in the outcomes that people experience. And obviously today we are focusing on cancer. So the body of the presentation is taken from the Cancer and Deprivation Report by Cancer Research UK, which was published in 2020. I could have looked at inequalities through a number of other kind of prisms, but I've chosen this today because I think it's quite thorough. Indices of multiple deprivation is a composite measure, so features things like people's experience of poverty, crime, housing, health, justice. So it's a kind of helpful way to look at health inequalities. So first off, I want to highlight that cancer incidence is higher for more deprived populations. Equates to 30,000 extra cases. 5.5% of all diagnosed cancers in England per year are attributable to deprivation. There's also a link to risk factors such as smoking, obesity. The higher incidence of those risk factors are reflective of the wider determinants of health, so our environments in which we grow up and determine our well-being. That demonstrates that a focus on those modifiable risk factors and that prevention. Calls for kind of action on modifiable risk factors, particularly for those from more deprived populations. We know that early diagnosis leads to better survival rates and potentially identifying curative treatment. Currently, 55% of people are diagnosed early, but the national ambition is to diagnose 75% at stage 1 and stage 2 by 2028, so quite an ambitious target. Those from more deprived backgrounds are less likely to recognise signs and symptoms. So So targeted campaigns are required that are designed for and with the communities most likely to experience these inequalities. So again, we know that early diagnosis is more likely to equal higher survival. Some cancer sites more deprived are diagnosed later at an advanced stage of their disease, and all that compounds to poorer chances of survival. It is a complex problem, but it's an unacceptable variation, and so we often need to look at how we remove barriers to screening, ensuring access to diagnostics to support earlier diagnosis. More deprived populations are also more likely to be diagnosed following emergency presentation. 1 in 5 cancers are diagnosed through emergency presentation, often at a later stage, and with worse survival rates. People are more likely to report worse experience, lower satisfaction with their care. Likelihood of emergency presentation is 50% higher in more deprived populations. So there's more that we can do to ensure that those cancers are picked up and those referrals are made earlier and outside of the emergency system. People from more deprived areas report more barriers to seeking help. You're familiar with the 1,000 Voices report. Routine and manual workers are more likely to be put off going to see their doctor than their managerial worker counterparts. There are also cultural barriers, such as shame. There are people concerned about wasting their GP's time as well. So there is more that we can do to improve access and reduce some of those emotional barriers as well. Hand over to us.
Thank you. So I think the key points from what we've heard so far, and I think all of you now sort of preaching to the converted, which is why you're here this Thanksgiving, but